Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary in the JCO article, TP53 Mutations in Low-Risk Myelodysplastic Syndromes with Del5Q Predict Disease Progression by Martin Yaderston et al. My name is Mikhail Sekaris, and I am Director of the Leukemia Program and Associate Professor of Medicine at the Cleveland Clinic in Cleveland, Ohio, USA. My oncologic specialty is leukemia and myelodysplastic syndromes. Our understanding of the myelodysplastic syndromes has exploded over the past decade, due in large part to the recognition that bone marrow failure is not simply a normal process of aging, and also due to the availability of medicines approved by the U.S. Food and Drug Administration to treat this disease. MDS actually comprises a heterogeneous group of clonal hematopoietic disorders that often result in cytopenias and have the potential to evolve to acute myeloid leukemia. According to U.S. epidemiologic data, yearly incidence rates of MDS have increased from 3.1 per 100,000 in 2001 to 3.8 per 100,000 in 2004, with 10,000 to 15,000 MDS cases diagnosed annually. It is estimated that 60,000 people are living with MDS in the United States. Approximately 70% of newly diagnosed patients have lower-risk disease, often defined as having moderate cytopenias, a bone marrow blast percentage of less than 5%, better risk or normal cytogenetics, and an International Prognostic Scoring System category of low or intermediate 1. Such patients have an expected median survival of 3 to 6 years. The remaining 29% of patients have higher risk disease, including more profound cytopenias, excess blasts, and poor risk cytogenetics involving chromosome 7 abnormalities or having 3 or greater lesions, with a median expected survival of less than 2 years. Lower risk patients often can be managed expectantly, particularly if their quality of life is preserved or with erythropoiesis-stimulating agents or other growth factors. Higher risk patients, on the other hand, typically require some form of disease-modifying therapy in an effort to delay progression to AML and even prolong survival. Within the lower-risk MDS group, patients who have the deletion 5q cytogenetic abnormality, particularly in isolation, have an exceptional prognosis with a median survival of approximately 6 years and an actuarial risk of AML progression of 18% at 5 years. These outcomes may be tempered in the setting of thrombocytopenia, excess blasts, and transfusion dependency. Patients with an isolated Del5Q abnormality who become dependent on red blood cell transfusions may be treated with the drug lenalidomide, with a reasonable expectation that up to 2/3 will become transfusion independent for a median duration of over 2 years. Survival and rates of AML transformation also may be worse in Del5Q patients who harbor additional cytogenetic abnormalities. In this issue of Journal of Clinical Oncology, Yaderston and colleagues, in a collaboration between the Karolinska Institute in Sweden and King's College London School of Medicine, the United Kingdom, reported on the frequency of TP53 mutations and the level of p53 protein expression by immunohistochemistry in 55 low-risk Del5Q MDS patients identified from 2004 to 2009 to assess their impact on disease progression. The TP53 tumor suppressor gene is the most frequently mutated gene in human cancers. TP53 encodes the p53 protein, which mediates anti-proliferative mechanisms in response to various forms of cellular stresses, in particular DNA damage, as might occur with chemotherapy. While it is known that TP53 mutations are seen more commonly in higher-risk MDS and in AML, particularly in conjunction with complex cytogenetics, and thus confer a poor prognosis, These mutations are rare in lower-risk MDS when conventional techniques are used to identify them. In this study, the authors used deep sequencing technology allowing detection of small subclones on bone marrow samples at diagnosis, during follow-up, and at the time of progression to higher-risk disease, defined as having greater than or equal to 10% bone marrow blasts and or evolution to a complex karyotype. Almost all patients had an isolated deletion 5q abnormality and fewer than 5% bone marrow blasts at baseline, and median follow-up was 40 months. 10 of these patients, or 18%, had a TP53 mutation at an early disease phase, and the mutation continued to be identified in all subsequent biopsy specimens. Half the TP53 mutated patients ultimately developed acute leukemia, compared to only 16% of deletion 5q MDS patients without a TP53 mutation. The corresponding time to 25% AML evolution was much shorter for TP53 mutated patients at 34 months and 151 plus months, respectively, with a p-value of 0.045, as was time to progression at 46 months and 151 months, respectively, with a p-value of 0.06. 37 of these 55 patients were treated with lenalidomide, including 8 of the 10 TP53 mutated patients. While small numbers of treated patients preclude definitive conclusions, it did appear that having a TP53 mutation impacted outcome even among patients treated with lenalidomide, as these patients had a trend towards increased rates of leukemia evolution and were less likely to have a complete cytogenetic response to the drug. Survival did not differ. Within MDS, data are accumulating that the abnormalities traditionally observed with classic metaphase karyotyping, seen in approximately half of MDS patients and most commonly involving chromosomes 5, 7, 8, and 20, are only the tip of the iceberg. A recent collaboration among the King's College, Cleveland Clinic, Johns Hopkins, and Tampa groups examining 430 patients with MDS overlapping with myeloproliferative neoplasms, and AML arising from MDS, used single nucleotide polymorphism, or SNP array technology, to identify chromosomal defects not seen with metaphase cytogenetics. The diagnostic yield of SNP arrays was 30% higher than classic karyotyping, identifying abnormalities in 74% of patients compared to 44% of patients, with a p-value less than 0.0001. These previously cryptic lesions also predicted for worse prognosis, including in patients with isolated deletion 5q abnormalities. The clinical importance of the findings in the current study and in the SNP array study cannot be emphasized enough. MDS is a cancer with a complex disease biology, the depth of which is only now being unraveled as sophisticated diagnostic techniques come of age. The discovery of mutations such as TP53, particularly as our methods for detecting these mutations become available and standardized across centers, will influence the initial discussions we have with our patients about their prognosis and the choice of therapy to influence that prognosis. MDS has a dark side, typified by the TP53 mutation, which can turn the best prognosis patients, those with an isolated deletion 5q abnormality, into tragedies. But it also has a bright future, as we identify these patients early and treat them aggressively to try to alter that fate. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.